Brian Eckman with Three Rivers Ambulance, going over some of our new blood equipment, just so you guys can see what you might see at the scene if you call for it. This big thing here is our blood cooler. It has a practically 30-some hour battery, but it does get plugged into our trucks, into our SUVs. So the SUPS vehicles, the chase vehicles, that's where these are going to be. Currently, we are managing 2 of these coolers on the street at a time. Each cooler has 2 units in it. So we can give up to 2 units of blood depending on the situation, the patient presentation and vitals. With this blood cooler, it also has a lot of tracking for temperatures because it has to maintain for that blood stability between 3 and 6 degrees Celsius. So it has, once you turn this thing on, and it pretty much is always on, it maintains that, and we can track what those are. The blood bank is very, very particular when it comes to their blood.
Oh, they are.
Very, very much so.
Rightfully so.
So one thing, I don't know if you can see, on the top we have this plus patch. If that is on here, then blood is in here. Now this is just simulated blood that's in here. So if we use it, then we'll take this patch off so that we know that blood is not active in here. We're also tagging this with the expiration date. So we are doing a 2-week rotation for our units of blood. If it gets used before that, great. And we can get it replaced through Lutheran's blood bank. They kind of loan us some until our shipment comes in. Once it's here, then we verify the blood, which will come in similar packs to this. This is fake, not real. So it'll have a paper. This one's a little bit better. I've got some copies so that you can see these. But on here, this will have all the numbers that are required on here. This will be full of stickers on the back, so we can just take those stickers off and identify them, and that's all it's doing, is for tracking purposes. Anytime we give blood, we need to verify vitals before we give them to make sure that they're within that period or appropriate, and then also every 5 minutes while the blood transfusion is going through. We are using a pressure bag or pressure infuser over the bag, so we should be able to infuse one of these within just about 5 to 8 minutes.
Yeah, pretty quick.
So if you're looking at volume, they're about 500 mLs per bag, approximately, because it is blood, so they consider it a unit, so sometimes it's over 450 but under 500. So
becomes much more important in pediatrics when you actually have to dose by mLs.
Absolutely, yes. A chase unit will be automatically dispatched for any kind of priority 1 falls, so adults over your 20 feet, pediatrics over 10 feet or twice their height, or 2 to 3 times their height. Any high risk auto accidents such as rollovers, party pins, ejection, motorcycle, if there's a death, reported death already, any kind of penetrating wounds to the head, neck, abdomen, chest, so gunshot or stabbings. Auto versus pedestrian, and then we're also sending on high risk OB if we're getting reports in the EMD process that there's a lot of bleeding, it will automatically send, as well as GI bleeds in the same condition. So if we're getting reports that there's a lot of blood at the scene, then they're going to automatically send.
And I just wanted to remind everyone that anyone can ask for a blood medic. The best route to asking for a blood medic is to get on TRAA's dispatch directly. This eliminates confusion and directly communicates to TRAA that you need a blood medic. As soon as you get on a scene and you recognize that your patient needs blood, again, get on TRAA's dispatch, let them know that you need blood or a blood medic immediately.
We now have these nice new bags, which has all of our supplies in it. So, along with our normal vitals, we also need to check temperatures. So we have new temperature thermometers in here, with also extra probes. Due to the hospital wanting to verify that we also have that this person actually received whole blood, we have these nice new wristbands that we will put on there on the patient. That way, not only do we need to make sure we're giving a good report, but then there's a visual reminder for the hospital that they have received some blood en route. our blood that we give en route also gets added into their
Yeah, the blood count.
the
Yeah.
blood count for their mass infusion protocols.
Right. In general, we go with only 4 units of whole blood, and that includes whatever was given in the field.
To go back with the whole blood, we are carrying O positive or O negative. Either way, it is whole, low titer, whole blood. So if it is O negative, which should be what we are normally getting, there are some concerns after the fact with any women that are of childbearing ages, just because of that positive negative for that they may need some ROGAM at the hospital. But that would be a verify at the hospital that that female was given O negative, low titer.
Well, the O positive is what really stimulates the antibody production that can cause, future problems with pregnancies. So that's the one risk of low titer O positive, which is primarily what we're carrying right now because of the O negative. It's such a small part of the blood supply in the blood donor pool. But the risk is very low. And the way we look at it is, if you're dead, you can't have you can't have a baby. That
Yes.
sounds pretty harsh, but in reality, we got to save your life.
And there's other options they can do after the fact,
Sure.
as far as if
Absolutely.
she gets
Yeah.
pregnant later. So just a concern for later on down the road. Obviously, we have to, hopefully this saves their life and then makes a difference. So I don't know if you can see. On the bag, there will be a temperature sensor as well. And this, as long as it's in the green, that means that the blood is good. Even though it's in the cooler, there's also a constant check with that if something had happened, the cooler went out of range, whatever, and the blood got out of its own range that it needs to be in, it'll indicate that it'll go black instead of green, and then we don't give it. Same thing as if we pull it out and it's expired. Same thing with any kind of medications, always have to verify the expiration dates. So in our bag, we will have our heater unit. Let me pull this out. So this has a battery that goes on the bottom, just snaps on. And then we will have 2 of the QFin or Warrior heating units. So this will just go on top and plugs right into the top like that. This doesn't normally come connected, but with trainings and stuff like that, we don't want to get stuff all over. So this here has to go, this Warrior unit has to be from here to here. We cannot do any extensions. So wherever your IV site is, or even an IO, has to be from here to here to the patient. So we can extend this end, but not this end. This has to be, so this needs to be next to or on top of. It does come with a clamp, and we do have an extension cable that would go between the heating unit power so that way we can go extended more towards the patient if we need to.
It's really nice. They warm up the blood really quite well and very quickly.
It was within seconds, I believe. I don't remember the exact number anymore.
I don't know why we don't have those in the hospital. We probably should.
But we can give the blood cold. We won't decrease the overall body temperature of the patient that much.
Yeah, New Orleans,
however,
I think, does cold
yes,
blood.
a huge system.
Maybe a degree, maybe if they got massive transfusion, but
But we want to make sure if we've got the heater, use the heater. If it's not available, if there's any issues, we can always do it just cold and still not have any serious repercussions. But we want to keep that in mind about hypothermia and our trauma patients.
right, the triad of death and trauma.
Absolutely.
Hypothermia.
So, like I said, we're just using pressure bags on our blood. So there will be 2 in our bags, and we're also stocking a blood set in every ambulance. That way, if there is a paramedic on the ambulance, they can already initiate, when they initiate fluids, they can initiate it with the blood set. So if you're not familiar with the blood set, you have 2 spikes, should have a filter, and then essentially a drip chamber. When you pull these out of here, you want to make sure that these are, both clamps are closed. I will take my bag of fluid and spike that. Doc, if you don't mind.
I'll be the IV pole, absolutely.
Thanks, sir. So once I have that, your saline bag spiked, then you're going to flush your line just like you would any other IV line. Make sure, oops, that one's close, perfect. So I need to make sure that my drip chamber is full, or my filter chamber is full. With the filter, you need to make sure that the fluid is above the top of the filter to prevent any air intrusion. And then it doesn't matter how much is in your actual drip chamber, as long as you've got a little bit in there. So I've got that full. I've flushed my line. Now I can start my fluids. I'm going to close this just for temporary, but now I can start my fluids while I'm accessing my blood. Part of the thing that you'll see and you'll be part of is with this paperwork, you have to verify the blood. So there's a there's a blood number, a donor number that's on there that has to match. You have to verify that it's not expired and that your temperature is still within range. Once that happens, then we'll assess vitals as we normally do, but then this needs to be filled out at a later time. But we have to verify that the blood is correct. So you'll spike your bag of blood. See if I can hold on to that. Just like any other fluid. I have that closed. So now, Doc, you got that one? Okay. So once I have both of them spiked, I'm going to close my saline and I'm going to open my blood. So I'm going to open my blood here. I don't know if you can see it, but then you'll see its color change as the blood starts running. See here, once blood actually gets to the patient, that is when we start our transfusion time. Not when we've spiked the bag or hung the bag or anything like that. Once transfusion is actually started, then we're going to go from there. We will put the bag on a pressure infuser. And then this works just like the ones that you have on the rigs. And then somebody will need to monitor this. I'm not going to keep pumping it up, but somebody will need to monitor this to make sure that this is holding enough pressure to deliver our fluid or our blood as fast as possible within a controlled manner. We're going to monitor the patient, take our vitals. Once we get through with the first unit, excuse me, we will reassess our vitals. If the patient still meets those criteria, we will hang the second unit of blood just like what we did here. While you're finishing this, you can, if you need to, you can go back to fluids while you're doing it. This will warm the fluids while you're doing that. So even if you're just giving warm fluids, perfect.
Yep. Yeah.
So let's see. So give the second unit. All right. The only thing different that we do for pediatrics. So pediatrics are 3 years old or older. They also fit within those trauma criteria. We use this life flow tubing. So this has kind of a gun-like deal. Still the same as your blood tubing. Okay, I still have 2 spikes, a filter chamber, and a drip chamber. What you'll see differently is I have an attached syringe. This is a 10 mil syringe. This gets loaded into the gun. Somebody get read me. Because with pediatrics, we need to check our volumes. So this is our best way to know exactly how much blood we've given. Every time you squeeze the trigger, it will pull back and draw in 10 cc's or 10 mLs of fluid, and every time you push it out, it will deliver that. So what we will have somebody in the truck doing is counting. So a pediatric, if they are under 50 kilos,
Right. Yeah.
because we're giving pediatric dose, let me back up. Pediatric dose for blood is 10 mLs per kilo. So if the child is over 50 kilos, we will do this procedure, okay? Because this is basically 500 mLs.
Right.
There's
Yeah.
their 50 kilos.
Yeah.
Anything under that, so if they're 30 kilos, then we'll use this because we need to do this 30 times. Because remember, each one of these is 10 mLs.
Yep. Yeah. It's perfectly designed for the administration for 10 mLs per kilo.
So, and then what we will make sure that whoever is doing the gun is actually counting out loud. That way, everybody that's in the vicinity knows where we're at as far as how much volume we have. The one thing that we need to consider is because, remember, we want to keep track of how much fluid and blood we've actually given, is from here to the gun is 30 mLs. So if we're going to stop when we do our calculation, we need to subtract basically 3 pumps. So if they're 30 kilos, this is included in that. That's 30 pumps, but I have 3 in here. So I'll do 27, stop it, and then flush my line. And that would be 1 dose. We can give 2 doses for pediatrics as well. So if we're at 30 kilos and we're going to give 300 mLs, I still have approximately 200 mLs left in this unit. I can go ahead and finish that out of this unit and initiate the last 100 out of the second unit that we carry. But we can give up to 2 doses for pediatrics, 2 units for adults. How's that? Once we've given that, we are still doing calcium. If they've had 2 units, it is 1 gram IV push. And then also TXA. So, but we're going to be switching from 1
to 2 grams.
to 2
right.
grams.
Yeah.
And then that'll be delivered the same way over 10 minutes in a 100 bag. If you've initiated the TXA before blood gets here, set your stuff up. Maybe TXA be finished, but this takes precedence over even the TXA. So, but the big thing is once you have blood running in this tubing, nothing else can go in that tubing. No IV, no other fluid or medication should be in that tubing. So if you do need to give calcium, TXA, push dose epi, anything like that, make sure you're doing it in a second IV site.
Now, if you've initiated blood and it's still transfusing while you get to the hospital, we'll stay with the blood. We'll finish that blood in the trauma resuscitation room. And then again, it's so important that all the labels and stuff come to the receiving facilities because they track this blood. And if the patient has a blood reaction, or if the donor, something happens and the donor ends up, they test it and there's some odd thing about the donor, then we track it back to who received that blood.
Yeah.
That's really, really important.
Yes, TRAA has to be responsible for that part. If the blood bank calls us and said there's an issue, they can call us and we should be able to track it to where did it go? Did we turn it back in? Did we give it to a patient? If we gave it to a patient, then we need to make notification to that individual. That's all part of this tracking process. Troubleshooting on this is pretty much minimal. The only thing that we've had a few times is when we went down to Newcastle, it alarmed even though it wasn't out of range, it was close. And then because we were driving to Indianapolis, we couldn't address it. By the time we got there, it had basically locked itself up and we couldn't do anything without pulling the battery. But this is pretty much self-contained. There's really no troubleshooting. We just manage to make sure it stays in range. If something is happening with this where it's going out of range, then we will pull the cooler and make sure that the blood's still good. And once it's out of the cooler, you should be spiking it, within a few minutes because you want to keep it in that temperature range. But it's not going to be outside of range for too long. Now, you shouldn't be pulling the blood out of the cooler and setting it off to the side and then start this process of connections. You want to make sure that start your blood set, start your fluid, got your warmer going, start running fluid, and then pull your blood out. If you want to leave the blood in and start doing your paperwork, fine. But then once you are ready to spike the bag is when you should be pulling it from the cooler. One of the times that we had was so the filter, when you know how we always swap them over, we throw all these on top of the patient and then move them over. Well, air had gotten somehow introduced into here, and so we couldn't continue because we don't want air to obviously enter the patient. So when we're doing these, one thing we've learned is that we want to make sure these are still hanging as we move our patient over. Stay hanging until it's done.
I think the other thing really is about stewardship of the blood. I mean, this program, when you're trading it out with a blood bank, it can still be utilized in the hospital.
Yes.
And we do. So we use whole blood for a massive transfusion for, a variety of exsanguinating conditions. So the blood utilization on the helicopters, as an example, we would almost waste maybe 50% of the blood from the last year. Whereas now, I think we're down to just a little less than 20% of wastage overall because of this rotation system. So it's a really great part of the stewardship of a very valuable resource.
It gets it out in more places for the availability, but still gets it back into the circulation for actual use before it expires.
Yeah.
Once it's out and about, it's about a 34 days of life.
Yeah, about a month. So.
Yeah. So, and then we are rotating that every 2 weeks on our end, so to make sure that blood gets back to the hospital, so they still have time to use it.
Right, and whole blood is a part of our massive transfusion protocols in the hospital. So the first cooler that comes to us has 4 units of whole blood, and many times they're nearing the end of expiration from the rotation, that's exactly what we wanted to do.
Thank you.